Nick Majerison here. Welcome to Top Med Talk. And today's Top Med Talk is from EBPOM USA 2018 in Chicago. And it's Frailty Assessment, Why and How. In this two-part piece, the issue of frailty is assessed as a diagnosis, whilst the realities of treating elderly people who suffer from it is looked at from a number of angles. It's a fascinating talk, this. Like I say, divided into two parts. Here's the first part. It's Dr. Bobbie Sweitzer, the Associate Professor and Director of Pre-operative Medicine at the University of Chicago. Now, of course, the Top Med Talk team is currently live in San Francisco preparing for the ASA. You want to listen in? topmedtalk.com is the place to go. Log on to there. You'll be able to hear the live stream, which is where, incidentally, this podcast you're about to listen to was first broadcast. So get yourself onto the website, topmedtalk.com, so you can listen to the live stream itself. And also, if you want to contribute questions, get to slido.com. I've got an event code for you here. You write this into the little box that it gives you. Hashtag TMTASA18. That's hashtag TMTASA18. Pop that into slido.com. It'll give you the option to vote up questions that have been already suggested by other people that you think are particularly good, and to submit your own questions, which will then be tackled on stage at the ASA here in San Francisco. So make sure you get involved with that. Okay, so let's crack on with the podcast in question, and that is Frailty Assessment, Why and How. This is part one. Part two, of course, to follow after this.
Top Med Talk.
Without further ado, Dr. Sweitzer will be speaking for the rest of the morning on frailty. Why do we have it? How do we manage it in the perioperative setting? Thank you.
Thank you, Anne-Marie. That was very kind. First off, you made me feel old, though, saying that I've been at this for a really long time. And secondly, my husband the other day said something like, a bunch of people were like, because I used to be at University of Chicago. I just came up here about 3 years ago. And he said, they were asking about you and everything, and they said, does she still like the fights? And I'm like, what? He said, well, the reputation is that you never met a fight you didn't like. And I found myself, it was kind of ironic, arguing with Saul Aronson, Dr. Aronson, about, not being, like the physician for the patient, and not, pigeonholing ourselves into this, we're just anesthesiologists, or we're just anesthesia providers, or we're just pre-op doctors. But I do think we do need to partner with our endocrinologists. We do need to partner with our cardiologists. We do need to partner with our primary care doctors. And we need to make this population health better for everybody. But I think we do need to realize that we have a certain expertise and a certain focus, and we want to really focus on optimizing the patient for the preoperative period, and not having one size fits all, and doing frailty screening on everybody, but trying to figure out who needs diabetes screening, who needs frailty screening, who needs anemia screening, and then focusing on that, and then referring the patients back to the providers who are going to be following them long term and can best provide for those patients. So what is frailty? Sometimes people use that phrase about pornography. And so I hope I got all your attention now. That, you know it when you see it kind of thing. So I think, we often think, frailty is just those patients who are like from the nursing home or the little old person, is walking with a cane. But we know that it probably, a lot more of our patients would meet the criteria for frailty. Frailty has been identified as a true clinical syndrome, a diagnosis for a long period of time in the medical literature. The geriatricians have really taken a lead on this, but I think only in the last couple of years or more, 5 years maybe at most, has frailty been recognized as an important identification or a specific syndrome in surgical patients, and that we really should be identifying a group of surgical patients that are likely to need special care or are going to be at high risk. In fact, it was interesting. I just took care of a patient just a couple days ago, and she was going to have an ablation surgery. And these are very long in the EP lab, and we almost always do general anesthesia because nothing else. It's really cold, and it takes a really long time, and the patients are probably bored to death. But, they're intermittently sometimes, putting these patients into these rapid rhythms. But this patient was going to have it was listed on the schedule as a sedation or MAC. And I figured it was just an error or misprint. But the first thing she said to me was, "You're not going to give me a general anesthetic, right?" And I said, "Well, that's, interesting. That's what the schedule said, but I assumed that was a misprint. Tell me about the conversation you've had with your cardiologist. And she said that her mother had had knee surgery at age 88 and was, quote unquote, never the same. She went in, she was healthy, she was living alone, she was driving, she was completely independent, and she had a total knee arthroplasty under a general anesthetic, probably unfortunately, and she had terrible post-op delirium, a cognitive decline, and ended up in a nursing home. And she didn't want that to happen to her. So then there was kind of a lengthy discussion we had about, what we know, what we don't know, and the possible risks, and, even with sedation. But, I think that idea that, if you're healthy at 88, if you're, or robust at 88, that you're just as healthy to have major surgery or just as likely to do well as the 40-year-old. And that's just not the case. And a lot of that, it's not age alone, and there are many robust, non-frail elderly patients, but age is one of the strongest predictors of the patients who are likely to be frail. So this is the official diagnosis. It's a clinical syndrome that often includes one or more of these kinds of just general situations of weakness, low energy, slowed walking, decreased functional capacity, and weight loss. And it's a multifactorial syndrome, but it's typically a chronic progressive condition that develops along a spectrum of severity. And because it's kind of like I mentioned this morning, anemia has almost become, it's okay, it's normal to have anemia. I think we just see these patients and think that many of our surgical patients meet the criteria for frailty, so it doesn't even flag out to us as being something that perhaps is abnormal or puts the patient at risk, or perhaps something that we could do something about. We know that frail patients are more likely to fall, have delayed recovery from illnesses, greater functional impairment. They may become disabled. They have higher costs. They may never live independently again. And they are more likely to actually die from having surgical procedures. Comorbidities do count. I just put one slide up here of one comorbidity, patients having major cancer surgery. And you can see that age does matter. I'm going to not just focus on age, but because age is probably the single most overwhelming criteria or marker of patients that are likely to be frail. Because sometimes patients who have chronic illnesses that are younger may appear to be frail, but that's probably a different syndrome in those patients. Because if you were very, very active and robust, and then you broke your leg, and over 2 weeks, a month, you had a sort of, medical illness, you do lose some ground, and you you have higher risks of complications, but you don't lose ground as rapidly as a patient who's elderly or who's already frail to begin with. And then when you have rehab after a major illness, as a younger, non-frail patient, you can regain your baseline much, much more rapidly than those patients who are frail to begin with. This is just another slide showing the impact of frailty based on different procedures, and I think that's really important as well. I mentioned this morning about cataract surgery. Cataract surgery is such an incredibly low-risk surgery that we, do it all the time in people who are in their 90s or are, very frail, and they do fine because there's a very low stress response and low risk to that procedure. In fact, it's probably less stressful to have cataract surgery, has been written in an editorial, than it is to get a haircut. But other surgeries have a major impact. And I think some of the surgeries that you see here, it's interesting. They have, I think, I was surprised at least. For example, a pancreatectomy is less risky than a colectomy in a frail individual, not in a robust, healthy individual, but in a frail individual. And why is that? Is that because perhaps we don't approach it the same way, that we don't allow patients who are the most frail to have a pancreatectomy, but we would allow them to have a colectomy, so therefore we see these kinds of results? Or it's because we don't treat them the way we should, perhaps. We don't identify that they need extra care, or perhaps nutrition or evaluation for things, or prehab or rehab. So I think that we often, get lulled into this sense that if it's a lower risk surgery, that then we can take care of patients who are higher risk. And I added another a couple of slides just last night because of an article that just came out in JAMA not too long ago, like a couple of weeks ago, I believe it was. But this was an article that I did, or a study I did with a group of people here at Northwestern, and we published it in anesthesiology, and it showed the cardiac intrinsic risk of a procedure. This is not overall risk of surgical procedures. We looked at just the cardiac risk. But what we tried to do was try to figure out, because I know often, cardiologists and their risk stratifying patients will say, well, it's a low-risk surgery. It's an intermediate-risk surgery. And we even talk about, right, low, intermediate, and high-risk surgeries. But I've always been puzzled by where that came from, because there's almost nothing in the literature that actually looks at the independent risk of the surgery. We often look at it, the patient along with the surgery, and we get some risk assessment, but we don't look at it just for the surgery. So we looked at the Nist database, which has millions of patients in it now. Dr. Heller mentioned some studies this morning about using the Nist database, which is maintained by the American College of Surgeons. It's a national database. It is not just academic medical centers. There's a lot of private practice hospitals in it. I think, in fact, a third of them or more are private practice facilities. And there's a few ambulatory surgery centers, but very few of those. Most of them are hospital-based practices, but they do very, very robust data gathering. They not only use electronic medical records to extract data, but they don't use billing records, which is really important because most of the big data that we use is based on billing records. And billing records can be very skewed and give us wrong information, but they actually use the actual problem list, the documentation, but they also, in addition to that, have nurses on site that are specially trained. They go through a program that the American College of Surgeons have to evaluate patients, and they do it at real time, not just retrospectively, but while the patient's actually in the ICU, while they're in the hospital. And they go and they talk to the family, they talk to the patient, they talk to the nurses even, to try to get very comprehensive data. So most people feel like it's one of the more robust databases that we currently have available, particularly in the United States, to look at outcomes and complications. And so what we tried to do is we tried to look at the surgeries themselves and extract out the risk of the patient. And we used as a sort of a baseline a relatively healthy 65-year-old man. And I'm going to point out just a couple of one particular surgery. And the reason I'm going to do this because just a couple of weeks ago there was a JAMA article about nursing home patients who had these procedures. So you can see if you're having a partial mastectomy or a simple mastectomy, and a partial mastectomy is a lumpectomy, it turns out cardiac risk is very, very low. The cardiologists have deemed that if it's less than 1% risk, that's considered a low risk, and they advocate no further testing for patients when they're at that kind of risk. So you can see having a lumpectomy is an incredibly low-risk surgery from a cardiac perspective. But this JAMA article that was just published looked at about 6,000 nursing home patients, elderly women, who had breast surgery. Some of them had lumpectomies and some of them had mastectomies. And they looked at 30-day and 1-year mortality as well as morbidity and functional decline. And interestingly enough, they found that even though in their assessment it was a less than 1% chance of death, and I just showed you that other one that showed, 0.22 risk, they found almost 9% of the patients died within 30 days of surgery. 31% of them died within 1 year of surgery. And of those that did survive to 1 year, 60% of them were significantly worse off than they had been before. Now, whether surgery significantly accelerated that or not is somewhat unclear. This was an observational study. It wasn't a randomized controlled trial. It was just showing associations here. But there's clearly signals that these patients are very high risk. And what was one of the most fascinating things that came out of this study was that the patients who had lumpectomies did significantly worse than the ones who had mastectomies. So again, we're back to that. Why was that? Was that because the sicker patients were only offered a lumpectomy, or was it because we thought it was just a little operation, and so therefore we maybe didn't treat the patients as aggressively or monitoring them as aggressively as we should otherwise? This is just the most recent study of nursing home patients showing that we probably shouldn't be doing surgery on nursing home patients. particularly surgeries like this. It's one thing to have a nursing home patient fall, break a hip, and decide that you're going to take your chances of possibly pinning that hip and getting that patient back to a little bit more of a functional level where they can transfer or maybe walk with a walker. But, it doesn't make sense to do something like breast cancer surgery on a patient who has this kind of mortality, whether it's related to the surgery or not. If a third of them are going to be dead in a year, I don't think they have to worry about their breast cancer contributing to that mortality. This was a study of the VA, and the VA has a similar sort of Nist database, but it only involves VAs in the United States. They don't have nearly as many patients currently in their database as the American College of Surgeons, and they use a slightly different methodology. But it's also considered a relatively robust database because they don't use billing data either, because they don't send a bill to themselves, the United States government paying for it. And they looked at things a little bit differently. They looked at just patients who were functional with activities of daily living, and usually that's defined as being able to, cook for yourself, bathe, feed yourself. These aren't patients who are, doing exercise. They're not out working. Just basically being able to function on their own, sort of taking care of themselves, not someone else. And they looked at a group that was fully functional and a group that was partially or completely dependent on someone else for activities of daily living, but they were not necessarily nursing home patients. In fact, most of them were independently living. And they compared that to ASA physical status scoring, which we're all quite familiar with. And it was interesting because they showed that basically if you're functional, you were functionally dependent on someone, it was like moving you into one higher level class of ASA. So, for example, the 3A patient, which is a ASA 3 patient who's fully functional, was the equivalent of a patient who was an ASA 2 patient who was partially dependent. And we know that generally that's where the big step up is in morbidity and mortality, is between ASA 2 and ASA 3. And so you can see that it was just like the equivalent of these patients didn't have any more comorbidities per their ASA classification. They just were the same on paper, looked the same degree of illness or sickness. But if they were partially dependent on someone else to take care of them for activities of daily living, it was the equivalent of being in the next higher class up. And again, this is looking at mortality. And I always say it's one thing to argue about morbidity. Did the patient really have a complication? Did they really have pneumonia or a wound infection? But when you've got a dead, cold body in the morgue, it's kind of hard to argue that, about that complication or that adverse effect. So let's talk about a patient. I know that often stories speak volumes to people. This was an 80-year-old nursing home resident who had colon cancer. So not dissimilar to that, the patient with the breast cancer. But this is often a little bit different because often these patients, are having bleeding. And this patient did have rectal bleeding, and he had had a couple of transfusions. And so then his primary care doctor decided that even though he was at high risk, he thought he should be referred to a surgeon to be considered for a colectomy. And when we sort of pushed back, it was interesting because he said, well, what are we supposed to do? Just let him die? And I was like thinking, well, we do all die. But is truly a colectomy the best option for this patient? Even if he is transfusion dependent, even though we talked about the harms of transfusion, it's a little different perspective here. Or there are really other choices. I mean, I think when I asked the a primary care doctor about if they discussed other choices, he said, well, what other choices are there? And I think he truly wasn't terribly well informed that there are other choices. We can send this patient to radiology, and they can perhaps cauterize something that's bleeding, even if it's a cancer. The patient can have colonic stents if there's a concern about obstruction, because often that's an argument that's made, particularly from surgeons, is, well, dying of obstructive bowel disease can be an uncomfortable, painful kinds of death. Or simply just comfort care and hospice care for this patient. Because the odds are often very, very much stacked against these patients, and they would rather, if they're presented with these kinds of choices, die in the comfort of their home or even their nursing home, rather than die in an ICU after very aggressive treatment. And it's interesting because, often the patient is not told. We all debate these things. I talk to the surgeon, I talk to the primary care doctor, and we have a big conversation. But we often forget to talk to the patient and find out exactly what they need or want and inform them. And so, we about 30% of nursing home patients older than the age of 65 who undergo colectomy will die within 3 months of surgery. 40% of the mortality is about 40% in those over the age of 85. And on average, about 40% of the survivors will have a significant decline in functional status. And 12 months after surgery, 50% have died. So this looks almost exactly like that other previous study I showed you of the patient with the lumpectomy, the women with the lumpectomies. And there's other studies of other specific surgeries that show very similar kinds of findings, it doesn't bode very well when you're in a nursing home to need surgery. But I think that it starts with, making sure that patients and their caregivers there has been a full discussion of the options. There's been a discussion about the possibility of complications in this functional decline rather than just this focus on whether they're going to die or not die. In fact, most elderly patients that's one of the least concerns they have, is that they will die, because they also realize that everybody dies. And as they get older, they realize that they too will die at some point. But what most older patients are most scared of and most want to protect is if they're not in a nursing home, they don't want to go there. And if they are already in a nursing home, they don't want to get in any worse shape, because they've often seen the other people in the nursing homes who seem to be worse off than they are even. And then who helps them weigh all of this? Because, as I'm going to cover a little bit later, unfortunately, part of getting older and also having frailty is this cognitive decline. And I think we also forget that, there is this option to do nothing. And do nothing is not giving up. Do nothing is an active decision that we make, that we choose a pathway that just doesn't involve, having something done in a medical sense.
Top Med Talk.
Don't forget you can meet the Top Med Talk team. We're at the ASA at the moment in San Francisco. And if you're here at the moment, why not pop along and say hello? There's been quite a few people actually who've come up to me and gone, "You do the voices on Top Med Talk, don't you?" I've had a little chat to them, which has been pleasant. So, like I say, if you want to be part of Top Med Talk and you're at the ASA, do make sure you find our stall and come along and say hello. And if you're not, why not? Surely you must be desperate to get to one of these conferences by now. Here's how you go about it. Go to ebpom.org/meetings for details on how you can come along to some of the conferences that we cover here on Top Med Talk. That's ebpom.org/meetings. That's your first point of call if you want to meet us in person. But also, when you're on the Top Med Talk website, do yourself a favour, sign up for the email updates. That's topmedtalk.com. And then get onto the email updates. Then you'll find out more about how you can get involved in everyone's favourite medical podcast, Top Med Talk. That's what you're listening to now. Don't forget to subscribe as well, and make sure you find us on social media so we can be friends online just like in real life. Twitter, Facebook, LinkedIn, we're on all of them. Have a little look. topmedtalk.com.